What nutrition and osteoporosis bone health? What is osteoporosis? Osteoporosis is a skeletal disease characterized by low bone mass and disrupted bone architecture, which increases bone brittleness, the risk of fracture, and loss of bone flexibility and stability. Osteoporosis is often called a silent disease because one can't feel bones weakening. Breaking a bone is often the first sign of osteoporosis, or a patient may notice that he or she is getting shorter or their upper back is curving forward. History of osteoporosis. Until recently, it was believed that osteoporosis affects mainly postmenopausal women and elderly men. The results of recent research, however, indicate that osteoporosis may occur in people older than 40 as well as in youths. The disease is more likely to affect women than men and is more prevalent in Caucasian and Asian females. Other contributing factors include low estrogen levels, genetic predispositions, low body weight, smoking, excessive consumption of coffee, and long periods of immobilization. Dietary factors which increase the risk of osteoporosis include a deficiency of calcium, 125 dihydroxyvitamin D, and protein 1. Osteoporosis prevention should begin early in childhood through the consumption of calcium-rich foods such as milk and dairy products to promote optimal bone formation. Causes of osteoporosis. There are many health problems and a few medical procedures that increase the likelihood of osteoporosis. These include autoimmune disorders such as ankylosing spondylitis, rheumatoid arthritis, lupus, and multiple sclerosis. Digestive and gastrointestinal disorders such as celiac disease, inflammatory bowel disease, and weight loss surgery. Medical procedures such as a gastrectomy or gastro bypass procedures. Cancers such as breast cancer and prostate cancer, neurological and nervous system disorders such as stroke, Parkinson's disease, or spinal cord injuries. Blood and bone marrow disorders such as thalassemia, mental illness such as depression and eating disorders, endocrine and hormonal diseases such as diabetes, hyperthyroidism, Cushing syndrome, thyrotoxicosis, irregular periods, premature menopause, low levels of testosterone and estrogen in men. Other diseases and conditions include AIDS and HIV, COPD, female athlete triad, chronic kidney disease, liver disease, organ transplants, polio and post-polio syndrome, poor diet including malnutrition, scoliosis, and weight loss. Symptoms of osteoporosis. There are no symptoms in the early stages of osteoporosis. Many times, people will have a fracture before learning they have the disease. Fractures of the bones of the spine can cause pain almost anywhere in the spine. These are called compression fractures. They often occur without an injury. The pain occurs suddenly or slowly over time. There can be a loss of height as much as 6 inches or 15 centimeters over time. A stooped posture or a condition called Dowager's hump may develop. The controversy over bone drugs. Standard osteoporosis treatment goes against U.S. Surgeon General recommendations. Using bone drugs as the first line of osteoporosis treatment illustrates a serious flaw in our medical system and goes against the recommendations of the U.S. Surgeon General. In the massive report Bone Health and Osteoporosis, the U.S. Surgeon General created an osteoporosis treatment pyramid that calls for nutrition, exercise, and lifestyle interventions to be the first course of action for treating bone loss and bone drugs as the last choice, and only after searching for the causes of the bone weakness. It's troubling that these guidelines are ignored by doctors who favor going straight to the top of the pyramid and prescribing a bone drug. Factors that tip the scales toward prescriptions include short doctor visits, lack of training in nutrition, confusion between bone density and bone weakness, quantity over quality mindset, and profits over health priorities. Short doctor visits. The average doctor's office visit covers 6 topics and just over 15 minutes. So suppose you are seeing a doctor to follow up on a broken ankle, a minor accident that led you to the diagnosis of osteoporosis. Your physician will take several minutes to examine your ankle and look at x-rays. How long does that leave you to discuss the fact that you have bone weakening? Maybe a minute or 2. Your doctor cannot cram everything there is to know about bone loss, exercise, and nutrition into that one visit. While he or she might use those fleeting seconds to suggest you supplement with vitamin D and calcium, it's more likely given that you've already broken a bone with concern about future fractures that will prompt what can be referred to as a magic bullet approach centering around the osteoporosis go-to prescription drugs, bisphosphonate drugs, a quick fix. Lack of training in nutrition. The reality is, a majority of physicians lack any significant training in nutrition, even though most of them recognize its importance. Keep in mind that your mainstream conventional doctor is an allopathic doctor, which means she or he is trained in the use of drugs, surgery, radiation, and chemotherapy to address health symptoms. Most likely, this doctor is not trained in nutrition and protocols that would naturally help the body regain balance, bone strength, and wellness. Confusion between bone density and bone weakness. In conventional medicine, there persists an overly simplistic understanding of what osteoporosis is and how it develops. Scientific studies have shown that bone quality and structural flexibility, not the total amount or density of bone present, is what most affects your risk of fracture. In many conventional practices, thinner bone is still conflated as weaker bone, and a bone drug is prescribed without further assessment. Quantity over quality mindset. Some bone drugs add quantity to bone but reduce quality. Remember, treating the symptom with a drug doesn't cure the disease, it simply masks the problem. The problem masking, in turn, often brings with it significant life-damaging side effects, and most physicians don't mention that these are very powerful medications with a profound impact on the body's most fundamental processes. Profits over health priorities. Bone drugs are big money makers, with the global osteoporosis drug market currently valued at over $14 billion and projected to rise to nearly $23 billion by 2030. Bisphosphonates account for 31% of bone drug prescriptions, roughly $1.25 billion per year in the United States alone. It's no wonder this huge profit opportunity has shaped the very diagnosis of bone health in ways that have improved sales, but not necessarily patient outcomes. Positive side of medications. Bisphosphonates are usually the first choice for osteoporosis treatment. These include Fosamax, a weekly pill, Actonal, a weekly or monthly pill, Beniva, a monthly pill or quarterly intravenous infusion, Reclast, an annual IV infusion. Most osteoporosis medications work by reducing the rate at which your bones break down. Some work by speeding up the bone building process. Either mechanism strengthens bone and reduces your risk of fractures. Bone building drugs include Forteo, Thymlos, and Evenity. These types of drugs are typically reserved for people who have very low bone density. who have had fractures or whose osteoporosis is caused by steroid medication. How to know which route is best for your bone health. There are people who have such catastrophic bone loss and bone weakening that it's appropriate for them to use medications to slow or halt it. These are usually people who have a serious ongoing health crisis, including patients undergoing cancer treatment, Paget's disease of bone, those on long-term high-dose prednisone treatment, or other situations where bone is eroding rapidly. These are clearly circumstances where strong medications can be beneficial, but that's in addition to supporting bones and overall health with nutrition and life changes. If your doctor finds your bone health situation so serious that she wants you to take these very powerful drugs, medications that affect not just bones but other systems in the body too, then your situation is serious enough to warrant a full osteoporosis medical workup looking for the causes of bone loss. The case for bone drugs cannot be made on the basis of just 1 or even 2 DEXA scans. The simple fact that a person is losing bone isn't reason enough to start someone on a drug. If there is an identifiable underlying condition that is causing an individual to lose a lot of bone rapidly, this should be identified and addressed. When there isn't an identifiable underlying health issue or an identifiable cause of bone loss, it stands to reason that working to support bones naturally is a better course of action. Improving nutrient intake, including optimal intake of vitamin D, magnesium, vitamin K, calcium, and the other key nutrients for bone health, exercising for bone health, and making other lifestyle changes are much more sensible first steps. There must be a very compelling reason to resort to bone drugs and only after careful consideration and investigation. Ethical concerns. Profits over health priorities. It's an unfortunate reality that for the U.S. healthcare system, the profit motive has pushed aside consideration of what's best for individual patients. Over a decade ago, one bioethicist warned that the pharmaceutical industry, which funds a majority of clinical trials, sets up a research agenda guided more by marketing than by clinical considerations. Smart statistical and epidemiological tactics help obtain the desired results. The budget for marketing is by far greater than for research. By contrast, powerful and cheap health-promoting activities are markedly underutilized. Technologies for changing behavior, an example being cardiac rehabilitation, palliative care, and use of old and effective safe drugs, all could benefit from industry's tools of marketing and quality. Clinical trials debate, right or wrong. The controversy about clinical trials debate, right or wrong. The controversy about clinical trials in osteoporosis is primarily focused on 2 points: the inclusion of participants who are highly susceptible to fractures, thus at risk from random assignment to placebo, and fracture used as a primary endpoint. Some experts argue in support of the need to adapt what they view as outdated guidelines for clinical trial standards that are more reflective of the current state of the field. Others maintain that the efficiency, endpoints, and study design required by the FDA are sound and necessary for robust research. Ethical standard for research. Clinical studies intended to support new drug applications, also called restriction or pivotal trials, must meet requirements set by the FDA. Although accepted efficiency, endpoints depend on the therapeutic area and indication. Inclusion of a placebo-controlled arm is fairly consistent across all fields. Placebo-controlled groups allow a clear assessment of the safety and efficiency of an active drug while limiting confounding factors. Example of an unethical trial. A large placebo-controlled randomized clinical trial in the field of osteoporosis research is the FREEDOM study, which evaluated the safety of denosum and found beneficial effects on the vertebral and non-vertebral fracture protection. Researchers for the study randomly assigned more than 7,000 women to denosum or placebo, given subcutaneous subcutaneously every 6 months for 36 months. In their NEJ editorial, Stein and Ray said, "There's a general agreement that placebo-controlled trials are unethical when a therapy that decreases the risk of serious complications or death is available." The debate. Many people believe that it is ethical to withhold ineffective treatment when adverse consequences are minor or rare. However, osteoporotic hip and vertebral fractures have serious consequences, including increased risk of death, surgical procedures, and long-term impairment of physical function. Inclusion of high-risk patients in clinical trial, ethical or unethical. Including patients with severe osteoporosis in a placebo-controlled trial puts them at unnecessarily high risk for fracture. Claire Coper said, "Rather, including those who have less severe disease would lower the potential risk for harm because they are less likely to experience a fracture. The choice is to either accept a modest amount of risk or a very modest amount of risk for each individual patient in a placebo-controlled trial in the more recent studies, with the advantage of being able to develop new treatments," he said. "If we don't take that risk, we will not have the chance to advance the field of osteoporosis treatment research. And in the long run, the whole population benefits from the investment that the participants in the clinical trial make." So who is suitable for enrollment in placebo-controlled randomized clinical trials? According to Rosen and Kostla, we would follow the recommendations of an expert panel that considered it appropriate to enroll patients with low bone mineral density in placebo-controlled trials if they had no history of fragility fractures or if radiologic imaging showed only asymptomatic morphometric vertebral fractures and patients who had side effects from previous therapies or who did not have a response to conventional therapy. How to prevent and or manage osteoporosis through nutrition. While osteoporosis can be caused through previous disease and or genetics, nutrition plays a big role in the onset for many people. Prevention and management of osteoporosis through nutrition can include eating calcium-rich foods as a part of a general healthy diet, which includes fresh fruit, vegetables, and whole grains, absorbing enough vitamin D, avoiding smoking and limiting alcohol consumption, incorporating strength training, and exercising regularly. Overall, osteoporosis needs to be made more known to the general public, as it is something we need to be aware of when choosing how to take care of our bodies, especially for those who may be more susceptible to it due to disease, genetics, or just because of dietary factors.